Hi again, folks. Welcome to the next lecture. This one will be on assessment and management of traumatic brain injury. So when we're talking about acquired brain injury, these typically occur due to a traumatic brain injury, a stroke, hypoxic injury or event, an infectious disease or brain tumor. This particular lecture will focus on traumatic brain injury. So when we talk about TBI, we're talking about physical trauma that's caused by some type of an external force applied to the head. So consequences of TBI might include immediate or subsequent death, loss of consciousness, coma, destruction of brain tissue, diffuse axonal injury, dysphagia, and or cognitive communication deficits. With respect to behavior, the behaviors associated with TBI include confusion, disorientation, amnesia, delusions, confabulations, making things up, poor emotional control, irritability, childishness, unreasonable behavior, and emotional ability, or inability to control one's emotions. There are two main types, well, technically three. There's the penetrating or open head variety, for example, a gunshot wound, the non-penetrating or closed head or blunt variety, which are of two subtypes, either acceleration-deceleration injuries, also referred to as coup-counter-coup injuries, where the head accelerates and then quickly decelerates, such as in the case of a motor vehicle accident. And then there's also non-accelerating injury, which can be caused by the head struck by some moving object, so a baseball bat or a pipe, for example, in a violent attack. Another variety is combat-related blast injuries. So this can actually be a combination, or can at least co-occur with closed or open head injuries. And in these types of combat-related blast injuries that you often see in veterans, these are caused by rapid pressure changes from a blast wave, so an explosion, and this can cause damage, diffuse injury across the whole body. There can be debris striking the body, shrapnel, causing various focal lesions. The body can actually be physically thrown against surfaces, which can cause either diffuse or focal injury, depending on what the body comes into contact with. And then there's other processes as well that occur during times of war, such as inhalation of toxic agents, radiation, and these typically cause diffuse injury. So focusing on closed head injury or coup-counter-coup, the moving head suddenly stops. The brain has inertia, so it continues to move and collides with the inside surface of the anterior skull. This creates the coup injury. So the brain goes forward and hits the bony structure of the inside anterior surface of the skull. And there are actually somewhat sharp bony protuberances inside the skull. So this can actually cause contusions, can cause lesions here in the front of the skull. Well, the brain will then rebound, reverse direction, and impact another part of the skull, for example, this point here. So the brain can actually come into contact with the posterior interior surface of the posterior part of the cranium, and can cause lacerations and impact damage in this region as well. So that's the counter coup. So coup, counter coup. In addition to this, there can be kind of a diffuse axonal injury as well. So diffuse axonal injury is kind of a widespread damage to the axons. So when the brain is kind of turned in the head, there's kind of a jerking, a twisting, a shearing of these axonal connections, causing stretching and tearing of these axonal fibers. And that can result in some diffuse damage to the axons. Now, some primary versus secondary factors. When we're talking about primary damage, we're talking about the lesions caused by the TBI, so the focal or diffuse lesions. However, there's also secondary factors as well. So these result from the primary damage. There could be things such as hemorrhaging within the cranium. There can be brain swelling, respiratory or cardiac failure that occurs as a result of the primary injury, hypotension or low blood pressure, ischemic brain damage, hypoxic brain damage. Brain damage resulting of lack of oxygen and nutrients supplying the various regions of the brain. There can be infection, and there can be delayed complications such as epilepsy and hydrocephalus as well. So just a few TBI statistics. TBI incidence occurs in about, it differs depending on the source you're looking at, but it's according to the J&J sources, there's between 150 and 362 cases per 100,000 individuals. In the US, about 500,000 individuals sustain a traumatic brain injury every year. It seems to be the case that adolescents and young adults have the highest incidence, and this is largely motor vehicle accidents. And then ages 65 and up and below 5 are the next highest kind of demographic group. And these injuries occur primarily due to falls. Males are twice as likely as females to experience TBI, and individuals with TBI are 3 times as likely to experience a subsequent TBI. There were some data from a kind of summarized in Solberg and Mateer as well. And these data indicate that falls were the most common. So this was probably in elderly individuals. Automobile accidents were next, and then assault was next. And there are other causes as well. So TBI severity, the seriousness of the TBI injury depends on the distribution of the injury. Are we talking about a single point, a focal point, a multifocal point, a kind of diffuse axonal injury? We're talking about a severe TBI in terms of the size, the location, the depth of the lesions. What type of underlying pathology are we talking about? The severity rating, it also depends on post-accident consciousness. So there are scales such as the Glasgow Coma Scale, which rate the severity of the traumatic brain injury. Coma duration is another variable that's examined to kind of rate severity, as well as the length of post-traumatic amnesia. And here you can see the Glasgow Coma Scale here. So it's rated on 3 aspects here: eye-opening, motor response, and verbal response. So for example, if the patient had no eye-opening, then they might be rated a 1. If they eye-open in response to pain, then they would be given a 2. If they open their eyes in response to speech, that would be 3. If it's spontaneous eye-opening, that would be a 4. So another test that is used oftentimes in traumatic brain injury assessment is the GOAT, the Galveston Orientation and Amnesia Test. So this includes orientation questions. So what is your name, wherever you're born, where do you live, where are you now, what city are you in, what hospital, and what date were you admitted to the hospital. So it's a lot of orientation type questions. And the Galveston Orientation and Amnesia Test is freely available online. Okay, in the case of mild TBI, this refers to a reduced capacity to pursue premorbid interests and daily activities at a comparable functional level. So mild TBI can range on a continuum from needing additional assistance to complete tasks to complete dependence on caregivers for basic needs. About 75% of cases are mild, according to some data. And when we're dealing with mild TBI, there can be multiple processes that are disrupted. It's not just one process. So attention, memory, executive function, organization, reasoning, communication, social skills, all of these can in fact be disrupted in mild TBI. And here is a definition of mild TBI provided by your textbook here. So trauma-induced physiologic disruption of brain function, as evidenced by at least one of the following. So a period of loss of consciousness not greater than 30 minutes, the Glasgow Coma Scale of at least 13 by 30 minutes after injury, loss of memory for events before or after injury, any alteration in mental state, focal neurological deficits. So these might be identified via imaging. So if standard imaging studies are done, they must be interpreted as normal. So they might be lost on the radiologist might not identify them upon examination of the CT or MRI results. So recovery from TBI. Recovery status post TBI does follow predictable stages, but recovery is specific to individual circumstances. Um, TBI is a heterogeneous population, meaning every TBI patient is different. They all vary in rate of recovery, the extent of the damage to the various neurological structures, kind of the distribution of the injury, the location of the injury, pre-injury abilities, a person's personality, the severity. These all are factors that influence a patient's recovery. So when looking at stages of recovery, your book provides a decent kind of a summary of these stages. So one might progress after an acute TBI from a coma stage where the individual is unresponsive with eyes closed to a vegetative state, so no cognitive responses, maybe gross wakefulness. The person might have sleep-wake cycles, to a minimally conscious state where the person is purposeful wakefulness. So they respond to some commands. Then a confusional state where there's some recovered speech, there is PTA, there are severe attentional deficits. The patient might be agitated at this stage, still not fully aroused, and possible kind of emotional ability, the lack of ability to control their emotions. Then there's a post-confusional state where there's evolving independence, perhaps a resolution of post-traumatic amnesia, cognitive improvement, achieving independence. They're starting to get their ADLs back. They're able to perform certain daily self-care routines again. Social interaction aspects improve and they start to develop more independence. And then there's a social competence community reentry stage. So this is the final stage where they are starting to recover their pre-trauma cognitive abilities. They're able to produce goal-directed behaviors. The social skills are reemerging. The personality starts to return to somewhat like the normal kind of the prior functional level state. They're developing independence within their community, and they might return to academic or vocational pursuits, although it might not be to the level that they were before. Okay, coma. In this stage, the patient displays minimal, if any, purposeful response to external environment. And in deep coma, the patient might demonstrate no discernible behavioral responses at all to touch, pain, sound, or movement, although autonomic or involuntary physiologic responses, blood pressure, heart rates, those might change with sensory stimulation, but that's not due to volitional action, that's just due to autonomic nervous system. With a lighter coma, the patient might respond to stimuli with kind of generalized responses, whole body movements, non-specific motor responses. And I should note that the predictive power of coma duration is not perfect. There are some patients that have a lengthy coma that can demonstrate good recovery, but there's also patients with no loss of consciousness that have extensive physical and cognitive deficits that never fully recover. So it's coma duration isn't a perfect predictor. There are also a few terms to define. Persistent vegetative state. This refers to patients who survive, but they never recover any degree of consciousness. So there's no higher cortical function, no speech or ability to follow commands. They may have an alerting mechanism, but they can't really follow any kind of directions. So this is typically made, the diagnosis is made after 3 months after a non-traumatic injury and 3 months after TBI. Another term is minimally conscious state. So in this state, there's minimal but definitive evidence of self or environmental awareness. So they're able to demonstrate some environmental awareness here. So this is more of a transitional stage. And this typically means they don't stay here. They're either improving or they're declining based on the trajectory of the neuropathology. So if it's a TBI, for example, it might demonstrate an improvement from a lower Glasgow Coma scale score, for example, or a lower Rancho scale score, or it could represent a transitional period within the context of a neurodegenerative disease where there's deterioration of abilities. And diagnosis of MCS is based on observation of one or more of the following behaviors. So they follow simple commands, they're intelligible in terms of their expression. They have a recognizable yes/no response. It doesn't have to be accurate, but they are giving a response. and then movements or emotional responses to relevant stimuli, they might not be, and then movements or emotional responses to stimuli are they are likely not attributable to some type of a reflex activity. They are somewhat volitional. Okay, orientation and arousal. So orientation refers to a person's awareness of person, so themselves, the place that they're in, the time that they are in, and the circumstances or the purpose. Um, why are they here? And orientation to caregivers. So, who are their parents? Who are their brothers and sisters, other family members, um, possibly to their doctor, their nurse, that sort of thing. Now, there's the orientation log. This is a good tool. It's available that has a nice score of orientation. With respect to orientation, I should note that person and familiar places usually return first. This was acquired and stored prior to the injury onset. So you're just checking memory retrieval mechanisms. Orientation to time, unfamiliar place, and circumstance require the capacity to take in, store, and recall new information after the injury. So that's we're looking at a lot more mechanisms in terms of the behavior, the memory function. So the typical order of return to function is circumstance, then place, then time, since time requires constant updating. Attention. So we've talked about this in a previous lecture, but I'll talk about a few things here. So concentration problems are common after a traumatic brain injury in long-term survivors. So we talked about the various types of attention. So focused attention, the ability to respond to specific stimuli like visually tracking an object. Sustained attention, the ability to maintain consistent behavioral response during a continuous repetitive activity. So like performing a shape sorting task, for example. Selective attention, so able to maintain a behavioral set in the presence of distracting external stimuli. So reading a newspaper with the TV on in the background, for example, being able to attend to the newspaper reading and ignore the TV. Alternating attention, which is the ability to shift focus of attention and move between tasks with different behavioral requirements. So a waitress serving tables and then also working the cash register, so going back and forth. Divided attention, which is the ability to respond simultaneously to multiple task demands, so driving and talking on the cell phone. And executive attention, which is the ability to choose the environmental aspects to which one is to attend and then carry out goals, so conflict resolution situations. So memory. So memory deficits are also common and persistent among individuals with TBI, but they typically co-occur with other deficits, so deficits of orientation, attention, language, etc. Approximately 54 to 84% of patients diagnosed with severe TBI experience memory deficits, so a very high percentage. And then approximately 80% of TBI survivors report persistent memory impairments as long as 7 years status post-injury. So this is a persistent problem, right? And difficulties can occur in the learning of new information, so the acquisition or encoding stage, storage or learned info stage, or retrieval. And there is some evidence to suggest that learning of new information is the primary issue with TBI. So as I mentioned previously, attentional deficits prohibit processing of info for later recall. So attention can be viewed as a window to memory. In order for things to be stored in your memory storage regions, then it has to actually pass through the window of your attention, right? So information must be perceived and understood to be remembered. There's also a few delineations that are made across different types of memory. So there's long-term memory, short-term memory, and working memory. So with long-term memory, a person holds on to information in their long-term memory storage indefinitely and has an unlimited capacity. With respect to short-term memory, however, there's a short duration and limited capacity. And working memory is kind of like short-term memory, but it's more dynamic. The information in it can be manipulated more easily. So the frontal lobe, and primarily the prefrontal cortex, coordinates the input from all other regions of the brain. And there are many interconnections between cortical and subcortical structures that form neural networks. So there are diffuse connections throughout the brain that are responsible for these executive functions. Executive function metacognition, so one's awareness of how you are thinking, or self-regulation, your ability to regulate your behavior in real time. So there's an awareness, kind of a discrepancy between the anticipated performance and the actual performance, and then a corrective mechanism to fix the problem. So self-regulating, being able to enact that change upon subsequent trials, or perhaps changing it in real time. That primarily determines the extent of social and vocational recovery. So can you return that back to your normal social and work activities? Executive function is kind of an umbrella function that interacts with all other realms of cognition, which makes sense because we're talking about interconnected neural networks, right? So there should be an interconnection between the functions, since there is a neurological interconnection between them, like a physical neurological connection between various regions of the brain. Executive functions include goal-oriented behaviors, such as initiating, planning, sequencing, organizing, and regulating behavior. And so when you have deficits in these areas, results in things such as impaired planning, impaired sequencing, and or monitoring of multi-step activities. Awareness of deficits. Anosognosia is a term that refers to one's unawareness of deficits. This is a very common problem after brain injury. So as high as 40% of individuals may experience anosognosia. This is a limiting factor for improvement of cognition, because if a patient is not aware of their deficits, you might have inconsistent participation. If you're not aware of the problem that you have, it's going to be hard for you to correct that problem, right? The degree of cognitive impairment and lesion site are predictive of anosognosia. This is common given anterior and cortical lesions versus subcortical lesions. So if the person has anterior cortical lesions, they are more likely to have anosognosia. There's this other issue of a lack of awareness versus denial. So denial refers to the subconscious psychological coping mechanism that it spares the patient the psychological pain of accepting the very serious consequences of the brain injury that is an unwanted effect on their lives. There are several different models of awareness. So for example, in model 1 here, the person might not have enough information or a limited ability to comprehend the information. Possibly they have the information, but they can't appreciate the implications of it. Or they could have the information and appreciate the implications, but they ignore the information to lessen the emotional pain. So that might be something kind of akin to denial. There could also be there's a few other models here. So the second model, the deficit, the anosognosia, could be due to intellectual awareness deficits, emergent awareness deficits, anticipatory awareness deficits, or the third model, then the anosognosia could be due to cognitive impairments, psychological reactions, or inability to recognize deficits just due to the severity of the brain damage. So there's different models of unawareness, regardless of which model is the most accurate. There are multiple things going on in the brain when a person does not have the ability to recognize their own deficits, and that is a limiting factor to therapy. So perhaps increasing awareness of deficits may be a target for therapy, depending on the patient. Aphasia. So the vast majority of TBI survivors do not present with aphasia. There is somewhat of an overlap between aphasia and TBI, however. So they both produce circumlocutions. So talking around a word without actually using the word itself. Various paraphasias. So a paraphasia is production of unintended syllables, words, or phrases during the effort of speech. And these can be phonemic paraphasias, neologistic paraphasias, or verbal. So a phonemic paraphasia might be papal for apple. Neologistic is like a nonsense word like pooth. And then verbal might be car for van. So it's a same semantic category, but a different word. Aphasia and TBI also both have reduced fluency and generalization of category-specific words, so limitations of divergent naming. So how many animals one can name in a minute, for example. However, TBI produces additional naming errors not seen in aphasia. such as errors of confabulation, which are bizarre responses related to the patient's disorientation. And as I'll discuss later, there are a number of standardized assessments that determine language impairments, and they were created for aphasics, people with aphasia. However, if one were to use them on an individual with traumatic brain injury, that assessment may not be sensitive enough to pick up on the traumatic brain injury survivor's deficits. It might rate them as being a neurotypical or normal individual, when in fact they do actually have some pragmatic language deficits. So confused language is often seen in TBI. So receptive and expressive language can be phonologically, syntactically, and semantically intact, but it lacks meaning because the responses are irrelevant, confabulatory or made up, circumlocutory, or tangential, kind of only tangentially related to the topic in response to a specific topic. They might lack a logical sequential relationship between thoughts. So it's confused. It's the semantics, the syntax, the morphology, the phonology might be there, but the pragmatic aspects are not. So this can be mistaken for fluent aphasia, but it's more appropriately considered as a symptom of cognitive deficits. There's this term, cognitive communication deficits, that is often used that refers to deficits of communication secondary to cognitive dysfunction. And I see a lot of individuals with cognitive communication deficits in my own clinical work in skilled nursing. So pragmatics. The primary language dysfunction in TBI patients seems to be related to pragmatics. So just to remind you, pragmatics are the system of rules that structure the use of language in social context. So persons with aphasia might communicate better than they talk, but TBI patients may talk better than they communicate because of these pragmatic deficits. So prefrontal cortical damage results in difficulties in discourse formulation, which we'll discuss a little bit later. Discourse is oftentimes assessed in TBI patients, and interpreting social cues, and in various abstract forms of language such as irony, sarcasm, symbolism, that sort of thing. Of TBI survivors have some type of a speech disturbance, some type of a dysarthria. And there is some evidence of apraxia of speech in individuals with TBI that is comparable to apraxia of speech resulting from left hemisphere strokes. However, this usually co-occurs with a language disorder. There is also some evidence that mutism, so lack of speech, can occur secondary to a severe TBI, where the patient has a preserved ability to comprehend simple commands and communicate non-verbally, but they are not able to produce speech. This is somewhat more rare, but it is something that has been observed. And if the mutism is associated with a basal ganglia injury, it tends to have a better prognosis than if it's associated with a diffuse brain injury. That might be permanent in that case. So the primary objective, the ultimate goal of traumatic brain injury rehabilitation is development of an individual to the fullest physical, psychological, social, vocational, avocational, and educational potential, consistent with his or her physiologic or anatomical impairments and environmental limitations. We want to improve their social skills, their ability to function in a variety of social contexts. So social skills include an individual's self-knowledge, their attendance to their personal appearance, various aspects of social communication, the communication itself, and aspects of the social environment. We can also talk about the World Health Organization's definitions of pathophysiology, impairments, activity or functional limitations, and participation. So pathophysiology refers to the interruption of normal physiologic processes, body functions, or structures through injury or disease. Impairments are losses or disorders of cognitive, emotional, or physiological functions. Activity or functional limitations result from the impairments. So this is the result of the impairment. And these are the effects of the impairments on a person's everyday life activities. And then there's participation. So that's the nature and extent of a person's involvement in life situations in relation to impairments, activity limitations, health conditions, and contextual factors. So the activity or functional limitations result from the impairment, which results from the pathophysiology. And then as a result of these activity or functional limitations, they might have reduced participation. So what is successful rehab? Reintegration of survivors into their communities in a meaningful and satisfying social role. So we want to treat the cognitive communication deficits that result from the TBI, and we want to increase functional abilities in everyday life activities. There's two main approaches. So the restorative approach and the compensatory approach. So restorative relies on neuroplasticity. So the brain's ability to reorganize itself and heal around the areas of injury. And this results in a functional improvement, and it's associated with repetitive exercise of these neuronal circuits. Then there's a compensatory approach. So with this approach, the assumption is that certain functions can't be recovered. So therefore, the patient, the SLP, and the caregivers together, and the rehab team must develop strategies to circumvent the impaired functions. There's one school of thought that states that compensatory strategies should not be employed until the restorative approach has failed. But there is some evidence that increasing a patient's awareness of their cognitive needs, so kind of addressing anosognosia, and teaching them to be strategic in approaching cognitively demanding tasks, that in and of itself can be restorative. So they're going through the process of developing strategies to address their limitations. So that itself is a difficult cognitive task. And so performing this kind of a difficult cognitive task can actually help restoration of function. So a practical approach might be use of both strategies simultaneously. So another dichotomy here is the traditional or process-specific approach versus the context-specific approach. So in the traditional approach, there is a hierarchically organized treatment with tasks targeting distinct components of cognitive processes. So one might progress from attention to aspects of memory to aspects of executive functioning in a systematic way, increasing length and complexity throughout the therapeutic process. So you're looking at the actual components of cognition. However, there's also a context-specific approach. And in this approach, treatment is provided by collaborating with patients in their daily environment to create positive, supported everyday routines of action and interaction in the context of daily living activities. So this might be seen as being more ecological or naturalistic. You're working on the context and the specific tasks that the patient is specifically wants to get better at. So this might be a better strategy if one was looking to improve generalization. So more research is needed to validate cognitive and communicative rehabilitation interventions for TBI patients. However, there are some guidelines provided by ANCDS and the ASHA-SIG-2 group. And they're listed here in this table in your book. So these include that management of cognitive communication disorders is part of our scope of practice. Management of cognitive communication disorders is interdisciplinary. It does not include interventions for aphasia or motor speech. It is an independent clinical entity. There are numerous approaches to cognitive communication intervention. There are numerous service delivery models. Improvements in impairments may not facilitate a change in the person's activity or participation level, and vice versa. So just because the impairment has been addressed, that might not result in a change in the participation level. And the ultimate goal of cognitive communication intervention is to achieve the highest level of communicative participation in everyday living. And there was a Institute of Medicine committee that found a lack of studies on cognitive communication rehabilitation interventions. And the majority of the evidence supported the efficacy of cognitive therapy for moderate to severe TBI in chronic phase patients. But there were some there were a lot of different techniques that were tried in the various studies, and there were methodological limitations and flaws. So even this research was not necessarily high quality, and it wasn't homogeneous in terms of the techniques that were examined. When we're looking at acute recovery stage and subacute stage, there's not a lot of evidence, unfortunately. So more research is needed. So when you're planning for your cognitive communication intervention rehabilitation, you need to consider both long-term and short-term needs. Are the treatment goals realistic? What's the patient's capacity to benefit from treatment? For example, if the patient is still in a unresponsive comatose state, that might not be like a Rancho level 1. We'll talk about that in a bit here. That is not necessarily the best time to try to start providing treatment. And whether the goals are realistic or not might involve the patient's capacity for taking what's referred to as an abstract attitude and also their executive functioning status. Major limiting factors for a patient to benefit from rehab might include impaired executive function, loss of abstract attitude, chronic attentional and/or memory disorders, learning deficits, and disorders of behavioral self-regulation and social interactive competence. The focus should be in rehab on the patient's real-world problems, not just the deficits identified by some standardized assessment. Because these types of deficits, the ones identified by a standardized assessment, are often very far removed from the everyday manifestations of a deficit. That's why you always have to do informal or naturalistic assessment in addition to standardized assessment. So relative to goal setting, the patient should always participate in setting the goals. The goals should be reasonable and client-centered. They should contain a description of the individual's behavior when the goal is attained. The methods for achieving the goal should be clearly delineated. All goals should be specific and measurable with definite timelines, and you should include both short-term and long-term goals. So stages of recovery after TBI include a period of unconsciousness, a confusion period, and a progressive return of cognitive functions. And here you see the Rancho Los Amigos levels of cognitive functioning scale from 1 to 8. So 1, we have no response. And then 2, we've got generalized responses, 3, localized responses, 4, confused agitated, 5, confused inappropriate, 6, confused appropriate, 7, automatic appropriate, and 8, purposeful inappropriate. So this is the Rancho scale here. And the timeline of recovery from one stage to another is variable across individuals because each individual is different with respect to the location of injury, the severity, etc. And the Rancho scale is a scale of progression of recovery of cognitive abilities in the traumatic brain injury population as manifested through behavioral change. The pros of this scale include that it doesn't require patient cooperation. You're only relying on observation. It includes behavioral descriptors of cognitive recovery along the severity continuum. It uses common descriptive terminology, and it provides a baseline for charting progress and for goal development. So here are the details of the Rancho. This is in your book here, so you can see the various scale numbers, the assistance amounts required, so kind of the definitional aspect of how much assistance is required for the person to kind of fall into this particular category here, and then some possible behavioral characteristics that might correspond to this particular level of function. So early stage of recovery, localized and generalized response. So we're looking at stages 2 and 3. A patient's function is dependent on their arousal level. And in these stages, assessment and treatment might be performed simultaneously. So you're constantly assessing and then treating at the same time. And one might look at both task variables and performance variables when performing assessments and treatments. So you might modulate stimulus intensity rate of presentation, the type of stimulus that is presented, and the types of responses required, the duration of the task and length of testing sessions, patient familiarity with the task, level of task complexity, and the context in which the stimulus was presented. And these are things that you can control and manipulate throughout your assessment and treatment. Then there are performance variables, which are aspects of the patient's response. So these aren't things that you control. So the response duration might be recorded, the delay between the presentation of the stimulus and then the response, the patient's ability to shift response sets from one task to the next task, the number of times the cue or the stimulus needs to be repeated for an actual response to be elicited, the actual type of response and the pattern of responses and the response consistency. So in these stages, the speech language pathologist must rely on observational skills. The patient is not typically able to participate in standardized testing at this point. The function is too low at this point. One might present stimuli across all input modalities. So you might use auditory, visual, and tactile stimuli. And then examine the effect of changing the presentation rate, complexity, the duration of presentation, the intensity. So you're looking at all of these different variables and how modulating each of them results and the response that results from changing each of these variables. And you might replicate this stimulation pattern to determine a patient's consistency of responses, both within and across sessions, to determine the consistency and progress. You will want to identify the patient's best, and by best, one might interpret that as the most consistent input modality and response modality, and then educate the other team members and the family members about these strategies or about these modalities to increase the communication between the patient and the team and the patient and their family members. So one high priority goal might be establishing a consistent yes/no response. Typically more automatic yes/no responses, so things like a head nod or a shake in response to yes/no questions are typically the easiest for the patient, or they might be recovered the earliest. The ability to follow yes/no commands consistently is often regarded as a turning point in a patient's recovery. So if a patient follows commands, then approximately 50% chance of progressing to Rancho stage 5, according to data. If the ability to respond to auditory and visual information returns simultaneously, then data suggests that there is a greater than 50% chance of recovery to Rancho stage 5. However, if the ability to respond to visual or tactile stimulation only emerges, and so they're not able to respond to auditory stimuli, then the likelihood for improvement was found to be minimal based on data. Should mention that there are other tools to assess function, such as the Western Neurosensory Stimulation Profile and the JFK Johnson Rehabilitation Institute's Coma Recovery Scale. So now the intermediate stage of recovery, so confused and agitated, and confused and appropriate non-agitated. So stages 4 and 5 of the Rancho. As patient alertness improves, they are bombarded with a multitude of stimuli from their environment. Because they're unable to focus and sustain attention for more than a few seconds, the stimuli can be perceived as being meaningless or confusing. Therefore, these patients might demonstrate marked agitation. For them, speech is often irrelevant beyond a few automatic social responses. This period is typically reversible in TBI patients, meaning that if a patient reaches this stage, they usually will improve out of it. However, there are some patients, severely injured patients, that remain in this period, so it becomes a chronic period for them. Agitation within this period typically decreases over time, but the patient is still unable to maintain a coherent line of thought or maintain concentration within these stages. There is still severe language disruption in these stages, even in the absence of aphasia, and language is confused, as we talked about previously. So there might be impaired attentional processes, initiation, maintenance, shifting, inhibition deficits, and these might affect language comprehension and expression. So, as we discussed, it's the intent and use of language, pragmatic aspects of language that will be significantly impaired in individuals with frontal lobe damage and TBI. And the characteristics in these stages include poor topic maintenance, topic shifting, ideational perseveration. So the patient might fixate on certain thoughts or ideas, verbal disinhibition, so saying whatever comes to their mind. And I've had a few patients like this. Impaired impulse control, confabulation, so making things up, impaired word fluency, inappropriate turn taking, like interrupting, inattentiveness to the listener's needs, repetitive or disorganized messages, and social inappropriateness. And standardized testing is not always practical because the patient's deficits might not be, because the assessment might not be sensitive to the patient's specific cognitive communication deficits. However, baseline data can be recorded, and you can document a pattern of recovery through standardized testing. And you'll want to take these data as early as possible. And your book provides kind of some guidelines for EBP for assessment of cognitive communication disorders after TBI, and some kind of recommendations here. So, of course, you should use caution in applying most standardized tests in assessment of people with TBI, because this is a heterogeneous population. And also, a lot of these assessments were not developed for patients with TBI. A lot of them were developed for people with aphasia. So anytime you're using a test that wasn't designed for a particular population, you have to take the assessment results with a grain of salt. There are 6 standardized tests that met the majority of criteria for reliability, validity, and inclusion of individuals with TBI in the test design and standardization sample. And so those include the ASHA-FACS, the brief, the CADL2, the R-bands, the TLCE, and the WAB. And I'm most familiar with the WAB, the Western Aphasia Battery. You should consider the results of the standardized testing within a broader framework. So you have to consider the person's pre-injury characteristics, the stage of development and recovery, the life and communication context, and you should integrate these types of standardized cognitive communication assessments with those of other professionals as well. So one might consider traditional cognitive rehab and speech language management in these stages, in these Rancho stages. And you might start process-specific cognitive retraining. So looking at specific cognitive domains, attention, memory, executive function. And this typically involves repeated administration of this hierarchically organized, of these various treatment tasks that target distinct components. So attention, memory, various aspects of executive functioning. And your book also provides these recommendations for the use of direct attention training. Who is a good candidate for direct attention training? What are the critical features of direct attention training, and what outcomes can be expected from direct attention training? It should also be noted that initially, patients in these stages might only be able to participate in individual sessions because group sessions can be too overwhelming. There's too much environmental stimuli. However, as the patient becomes more oriented and less confused, one-on-one sessions can be supplemented by group therapy. And group therapy is very useful because within a group, you can assess generalization of targeted behaviors in more of a naturalistic setting. And you can assess social skills and train social skills and facilitate interactions with peers. Computer-assisted therapy is also an option, and it's good for repetitive drills, especially. And you'll want to start family, caregiver, education, training, counseling, interdisciplinary consultation, and discharge planning. And this will kind of be ongoing in these stages. And later stages of recovery. So interdisciplinary evaluation is critical. In these patients, the deficits might be subtle. And so, for example, you might assess the patient's cognitive communication skills while an occupational therapist analyzes their performance of ADLs. So you could assess their cognition and communicative skills while the occupational therapist is assessing various functional aspects, motoric aspects of their function. And then the SLP can analyze the effects of the impaired cognitive communication on the performance of the patient's daily activities. As I mentioned before, this is a heterogeneous population, and so therefore evaluation must be tailored to the specific individual. So what is the patient's specific injury? What is the severity level? What are the communication needs? And the evaluation at these stages can provide baseline data to measure improvement across time. It can help differentiate diffuse versus specific cognitive impairments. So does the person have deficits in attention, memory and executive function, or just executive function, or particular areas of executive function? It can facilitate identification of processes responsible for communication breakdown, and it can identify a point at which remediation should begin. So with assessment, you can focus on the impaired processes via formal assessment. So in these assessments, you can look at specifically at attention, at memory, at executive functions. And then you can also look at the impact of these deficits on everyday tasks via informal or naturalistic assessments. So we should use both formal and informal assessments. So with respect to standardized assessments, these are most appropriate for TBI patients in the late stages of recovery. However, as I mentioned before, interpretation must be done with caution. You can't compare one patient to another patient, but you can compare a patient before and after therapy, for example, or at this point in therapy and at a later stage in recovery. Given a patient with milder cognitive deficits, for example, organization, integration, other executive function deficits, this patient might require a more detailed, more specific evaluation that kind of assesses these other aspects of cognition. So, for example, the slums or the MoCA would be more appropriate than the GOAT, for example. And here's the GOAT again, and there's a website that you can get the GOAT. As you can see, this is a orientation and amnesia test. So there is a somewhat minimal assessment of executive function in the GOAT. Okay, naturalistic or informal assessment. So deficits that are not observed or are not evident during formal testing can become more evident during assessments in unstructured or everyday environments. For example, you might find that the patient has a difficult time with selective attention tasks, for example, reading with the TV on, where this might be something that they had no problem with before, and now they might have a problem with it. There is a specific type of naturalistic assessment that's referred to as ongoing, collaborative, contextualized hypothesis testing assessment. And this operates under the assumption that vocational or academic performance and social behavior of patients with traumatic brain injury is influenced by the context. Therefore, assessment must be contextually based. It necessitates collaboration between the patient, the staff, and family caregivers to facilitate compliance to interventions, and takes into account the complexity that's often seen in the TBI patient. There can be many possible explanations for difficulties across various realms of vocational, academic, or behavioral. And so therefore, hypothesis testing is needed to kind of confirm where the specific deficit areas are and what the best intervention strategy might be. And your book supplies a little overview of some aspects of hypothesis testing assessment. As I mentioned before, pragmatic deficits are often the most pervasive deficit in traumatic brain injury patients. And TBI patients tested with standardized assessments that were originally designed for aphasic patients, for patients with aphasia, can be insensitive to the deficits seen in TBI patients. So the TBI patient might just appear to have minimal deficits, according to the results of these tests, but still demonstrate very significant functional communication issues in naturalistic environments. So one way of assessing these types of patients is through discourse analysis. So discourse is a series of related linguistic units that convey a message. And there are a variety of types of discourse. So these include descriptions. So a description is stating static attributes or relations of things. There's narratives, which that is stating actions and events that unfold in time. Procedures, which is providing instructions or directions in a specific order. There's persuasion, so giving reasons or facts to support an opinion. And conversation, interactions with others. So discourse might be the most natural and basic unit of normal verbal communication. So therefore, one would want to assess discourse because discourse tasks require complex interaction of linguistic, cognitive, and social abilities that are very commonly disrupted in TBI patients. So therefore, we want to assess these types of skills, these types of tasks. With discourse analysis, one might begin with a spoken narrative, so maybe a 5-sentence minimum, and then the narrative could be transcribed and divided into what are known as T units. So these are an independent clause plus any associated dependent clauses. And then you could measure the number of T units as a measure of narrative length. And your book supplies some examples of narrative story analyses here. With discourse analysis, you could also look at the number of dependent clauses as an index of grammatical complexity. You could look at what is known as intersentential cohesion, which is how an individual links meaning across several sentences. You could look at productivity measures, such as total words produced or total speaking time. You could look at content measures, such as accurate content units, or you could look at conversational speech measures, such as appropriateness of the utterance or topic maintenance. And there's also pragmatic scales that you can use as well. So if you go back to the previous slide, you can see a few discourse measures, so words per T unit, subordinate clauses per T unit, measures of cohesion, cohesive adequacy, percent complete ties of total ties, number of total episodes, proportion of T units within episode structure. So these are just some measures that one can use to kind of quantify discourse. Here are some examples of analyses for conversation that have been applied to TBI patients. So response appropriateness, analysis of topic, exchange structure analysis, generic structure potential analysis, mood and modality analysis, conversation analysis, pragmatic rating scales, and social information processing. So these are other types of analyses for conversation that are available and that have been used in the literature. Treatment in later stage traumatic brain injury patients should eventually focus on carryover of treatment goals to home and community environments. And this is not to say that carryover should not be present throughout the entirety of therapy, but really there should be a shifting of focus to a primary focus on carryover at this point. There should be consultation with teachers, employers, coworkers. If, for example, a TBI patient is planning on reintegrating back into their school or work environments. And so there's some education that can be provided to these individuals. The ultimate goal is sustained community reentry at the highest possible level of productivity, independence, and social adaptation. And evidence suggests that functional gains may be most easily achieved when rehabilitation is performed in the patient's home and community and involves activities of high interest. So for example, the SLP might perform therapy at the individual's home or various community contexts. So for example, home health therapy. So in treating TBI patients, you're going to want to consider functional real-world outcomes, success likelihood or prognosis, and the interrelationship between deficit areas. You want to define the problem in functional terms. You want to provide therapy in naturalistic environments that can facilitate generalization. And remember, the traumatic brain injury population is heterogeneous. Factors such as time since injury, the severity, the patient's age, their level of education, their prior level of function, these all need to be considered. And what works for one patient might not work for another. Therefore, you might have to do some trial and error, some hypothesis testing to really determine what the best method is to improve the function in this particular patient. All right, so that concludes this lecture. Thank you very much, and I'll see you in the next one.